Today's Academy Mentoring Moment. So the questions for this month go to interesting and challenging cases, developing your deep resources, and where you get your evidence. I'm going to use those underlying questions to tackle some more challenging ones and probably go break it up into three parts. The part I'd like to talk about today is learning from your patients, and in the framework of being an orthotist, we get an awful lot of the bottom of the barrel. We've given up on anything. Maybe the orthotist can figure out something for them. Now with that, we will see some particular diagnoses more than any one physician, because the nature of the patient's pain, discomfort, or dysfunction drives them to a device from all sorts of different physician resources. So with that in mind, you should be reading the diagnoses for your patients. And if it's something you're unfamiliar with, Google it before you get going. But once you're in that room with that patient, it's important to say, hey, I'm not familiar with this. Chances are you can tell me a lot about it. So can you share with me some of your experience and getting this diagnosis and what it means and what's going on with you? You'll learn a lot that way. Now, sometimes we'll have a diagnostic code that's just like right foot drop, and we don't get the broader understanding of what's going on. So in those times, it's helpful if we ask the patient if they have a broader diagnosis, if they know what the underlying cause and problem was, and see if we can learn from them there. So please learn to check your diagnostic codes, understand, I know what this is, or no, this is something new and different, and have the conversation with the patient to learn from them. And that should be an easy conversation. Now, I mentioned the bottom of the barrel thing. So there are some particular diagnoses that, because of our field sort of acting as undergirding for all sorts of problems, you will get to see a lot of, even though they are very small things. And I'd like to list a couple of those because chances are you can make a big difference for people here. The ones that I'm going to list, I'm going to say from the least common to the more common, and that's going to be Ehlers-Danlos syndrome, what's now called regional pain syndrome, multiple sclerosis. So there's just three. So let's talk a little bit more about these. The nature and pattern of what we see from the physical side with these three diagnoses is easy to see when you've seen a bunch of it. It's fairly easy to recognize the pattern. And because at this point, MS is relatively easy to diagnose, but there's still challenges there. But the others are fairly challenging to diagnose among non-specialist circles. And so you'll see these patients present where they don't have a diagnosis. And yet, if you've been paying attention to your patients that have these diagnoses, you'll be like, that looks just like Joe. I wonder if. Here's an awesome opportunity to do a little deeper dive of questioning with your patients you'll typically discover that they've had some struggle in figuring out what their diagnosis is. They might have something that, sort of makes sense. And yet, your experience is probably right in that, like, no, oh, this might be Ehlers-Danlos. And here's where we want to step up as a medical professional and make sure that patient's being cared for. But there's a lot of challenges with that. So, looking out for the patterns, asking your patients questions, developing the experience where you can see these things puts you in a position where you can have a conversation with the patient's primary physician or the one specializing in their current diagnosis and inquire if, I saw your patient, Dr. Jones, and it looked to me like there might be Ehlers-Danlos. I've had a couple of those patients. I know they didn't have that diagnosis, but is that something that's been considered and ruled out, or might that be part of what's going on here? Or sometimes it might be as simple as, if you have like a neurologist that's a fantastic specialist in MS, and they haven't seen that neurologist, it might be as simple as, patients in front of you, would it be okay if I suggested to your physician that you visit with my neurologist specialist? Because they may need that specialist to get an appropriate diagnosis. And your patient's never going to be upset at you for recommending something that gets them closer to the appropriate diagnosis and appropriate treatment. Now, you do have to understand that if the physician who's referring that patient to you may not be communicative or work as a team much or comfortable with you referring them to a neurologist, you have to negotiate all that. And so you do have to figure that out. But it's worth doing that when you see patients that have particular problems, and from the patterns you've seen because you take care of these patients, you realize that that looks like that might be. So invite you to ask deeper questions of your patients. Learn from your patients when it comes to asking them questions about their diagnosis. Pay attention to these odder things that we wind up taking care of. Develop pattern recognition when it comes to the way those pathologies present, and advocate for your patients to make sure that they get good diagnoses and good treatment. So please remember, we're not physicians. Officially, we can't diagnose at all. But because of the nature of our field and what we do, we will see things a lot that other people simply don't see. Don't close your eyes and ignore it. Look for it and make a difference in your patients' lives. So I'm going to wrap this part right there today. And next week, we will dive into some of the challenges that comes that comes with communications with physicians. Thanks.